The treatment of gastric cancer after relapse unfortunately happens too often because most patients with gastric cancer will in fact have recurrence. So I think one question is the timing. If let's say a patient received perioperative FOLFOX therapy and surgery, and then 2 years later developed recurrence. In my view, all treatment drugs are available, and so I might consider a platinum 5-FU combination in the first line setting. If, however, patients receive FLOT therapy perioperative and unfortunately had a recurrence within 6 months, our options are limited because they have probably primary refractory disease. I might go with FOLFIRI or something like that, something that's non-cross resistant. So I think the details of the timing matter in terms of time to recurrence. But for most patients, the recurrence tends to be a year or later, so I would consider all drug options as an option. A key question with regard to this is the molecular testing. So we commonly do the molecular testing on the primary tumor, and if they're HER2 positive, we use that. If they're PD-L1 positive, we use that. These markers in gastric cancer tend to be dynamic. So if you're HER2 positive and you receive trastuzumab in the first line setting, about 30% of the time, you will lose your HER2 positivity at the time of progression. So in effect, trastuzumab maybe killed the clone that was HER2 positive, but the remaining clone that developed resistance is HER2 negative. And that may be why second-line trastuzumab or T-DM1 or lapatinib actually is ineffective. So if I were to try to consider second-line therapy, I would biopsy and check to make sure they're HER2 positive in the second-line setting. With regard to mismatch repair deficiency, there's no evidence that changes. So we tend to test that in the primary tumor, and if they're mismatch repair proficient or microsatellite stable, I don't re-examine that in the metastatic setting or at the time of recurrence. And in terms of PD-L1, there are lots of data that PD-L1 is a dynamic marker, and chemotherapy and radiation can in fact induce PD-L1 staining, but we don't really have much data on repeat biopsy and changes in PD-L1. So right now, that's not an indication to repeat a biopsy, but I wouldn't be surprised if that changes in the future.